Oh, hello. This is Jeff Guy. I'm Vice President of Clinical Services for HCA. Today we're talking to Dr. Paul Silka, who's the Medical Director of Regional San Jose Medical Center in San Jose, California, who is really on the leading edge of the wave of COVID as it entered into the United States. And we're hoping to get some lessons learned from Dr. Silka today regarding his firsthand experience relative to COVID in the emergency department. Welcome, Dr. Silka. Give us a little bit of background about your emergency department and your first experiences with COVID.
Sure. Thanks, Dr. Guy, for bringing me onto the show. I'll tell you a little bit about Regional Medical Center. This is a level 2 trauma center in San Jose. We're actually in East San Jose, which is a relatively underserved community, although in general, San Jose is thought to be the heart of the Silicon Valley. So it's a very vibrant, dense area. So day in and day out, we see about 250 patients a day. We probably have about 3 to 5 trauma alerts daily. And we are also a STEMI receiving center and a comprehensive stroke center. So we tend to be pretty busy.
So obviously a very large emergency department in an urban environment. You've got a rather diverse population that you serve as well, as I understand?
That's correct. The makeup of our community is probably about 60% Hispanic and probably about 30% Pacific Asian and mainland Asian population. So very diverse. We probably speak 3 or 4 languages with the help of a translator, of course, during any given shift. And with it comes, unfortunately for some of our patients, but from a medical standpoint, a very interesting case mix of pathology day in and day out.
Now, I believe that you were probably still in the single digits of COVID cases in the United States when you and your team first experienced COVID, and you had a pretty intense first month and a half. Can you give us a little bit of insight what that was like and what lessons you learned, and if you had any do-overs, what those do-overs would be?
That's right, Dr. Guy. We experienced a early encounter with many COVID patients. It turns out that Santa Clara County, which is in the South Bay region of San Francisco Bay, was probably inundated with COVID early in February, if not before then. And given the community that we're in and travel what it is, we probably had COVID in the community quite early in this pandemic. In fact, even before it was a true pandemic, officially by WHO, World Health Organization. What we saw was an influx of ambulatory patients during that first phase. And in retrospect, we've kind of designated 3 phases, if you will, of the pandemic as we experienced at Regional Medical Center of San Jose. The 3 phases we've broken out loosely into the vertical phase, the mixed phase, and the horizontal phase, and that's in succession. The vertical phase, we saw what we now term walking COVID. And walking COVID, like walking pneumonia, were a cohort of patients that presented, and they presented with mostly respiratory complaints, although sore throat was common, and some mild GI symptoms, cramping and diarrhea, were not unusual. They, however, generally had cough and fever with other general like influenza symptoms, body aches, headaches. At the time, we weren't sure, as there was no testing available, we weren't sure if we were seeing the end of our seasonal influenza cases or if this was in fact true COVID. As soon as we understood that there was COVID in the community, we were very strict about separating our patients with ambulatory respiratory complaints from the rest of the department, with the intent that we would essentially start to give some social distancing to our patients who are ambulatory from staff as well as from themselves. So we put them into a cohorted area that had some degree of negative pressure. They were given masks. Our staff had personal protective equipment, and we started to go through these patients, and we started to learn quite a bit about COVID. So that was phase one. Interestingly, we had anticipated that there might be a significant surge of more sick patients or even a higher degree of surge than we saw. And so we did have our disaster tent set up with plans to operationalize to move those patients into our disaster tent and have some staff out there. But the fact of the matter is we never actually saw that great a degree of influx where we needed to operationalize that disaster tent.
I mean, that's very interesting. So you began to get the sense that something was awry, that this could be potentially COVID because you were getting kind of atypical influenza relative to seasonality. And so that really brought up your antenna to begin to cohort your patients and take extra precautions before those measures were actually kind of recognized.
That's correct. And we got good support from nursing and medical staff to kind of do a split care model in the emergency department, splitting these patients out. And as I said, we were fortunate that we had a large unused area that had been used for influenza overflow in the past. We didn't need it to a great degree during our peak influenza period. We had operated it on Mondays and Fridays, but it kind of seamlessly transitioned into what I termed as the walking COVID clinic.
Wow, that's incredible. And then walk us into your phase two, or what you call the mixed phase.
Yeah.
These patients became higher acuity.
Yeah, and of course it wasn't the exact patients, although there were some patients that they themselves came in with the early respiratory complaints of what we know is the natural history of the disease for COVID-19, presenting with fever, some cough, shortness of breath. Those patients were discharged. By and large, they went home, and we believe that they recovered well and without complications. They were told to self-isolate. But we also had a cohort of patients that we did pseudo-scheduled follow-up examinations in the emergency department. And we were very explicit. We said, return in 48 hours if your symptoms have not improved or particularly if they've worsened. Common sense, but it was important to open the door to these patients. We did see a lot of these patients return not getting worse. We saw a good number of patients return, probably in the range of 20% or so, that actually did get worse. So this was our mixed phase, or phase two, where these patients couldn't ambulate down to our COVID clinic. They actually needed to be put into isolation with, at that time, negative isolation protection for staff, negative isolation rooms, full PPE. And then we also started to receive a high number of EMS transfers in, and these patients were in respiratory distress, impending respiratory failure. So we had this mixed model of patient presentations in phase two. A good number of these patients at this point were now being admitted, and during this phase two, on the inpatient side, we started to see the ramp up. A dedicated COVID unit for telemetry, and then a separation of ICU COVID patients from our other ICU players.
Wow, it's incredible to keep track of that all. How did you coordinate with EMS as far as traffic coming into the department and not contaminating your department? And also, how did you partner with your EMS agencies to protect the paramedics and EMTs to develop protocols with them, for responses?
There was a pretty fair exchange of information given our network. So as they were learning and as we were learning, there was shared learning through the usual and customary network. One of the first things we did, and actually Garrett was there, I think it was a Friday afternoon in late February, we actually cordoned off our EMS bay with parking or traffic delineators, and we actually had police tape up. We didn't fully operationalize it, but we used that as a visual cue to EMS, and then very quickly formalized our recommendation to EMS that prior to entering the emergency department, they stopped in the EMS bay, and we exchanged information, if you will, at the gurney side to make sure that a patient wasn't high suspicion for COVID-19. Now, in the early phases, we relied on, how do we say, good citizenship. Subsequently, over the course of the next week or two, we actually locked down that EMS entrance. Again, we tried to communicate all of this out in operational memos. The first memo was something to the effect of, please pause at the doorway, and then subsequently the memo was something to the effect of, we apologize, but we had to lock the EMS door so we could carry out appropriate screening of your patients. So that's how that progressed. And as you might expect, this stuff wasn't necessarily elegant. A lot of it was just in time, and we bumped along with these iterative improvements as we went. But in general, I think we accomplished the goal, which was making sure that we got the right patients to the right setting within the emergency department, doing our best to prepare our staff and protecting the patients that were already in the department from COVID-19 as they were transitioning.
That's interesting. And as an individual clinician, but also as a leader in the emergency department, what would you say has been your largest clinical challenge in the provision of care in emergency department, but also leading that department?
Yeah, a couple of pieces to that. This, of course, is novel, and this new disease, we were all learning as we went. So significantly on the provider side, but we did our best with nursing as we learned details of the disease, how it presented, what these patients looked like, and then correlated that to what was dripping out in the scientific community and the lay press. It goes back to what is always the case in management, which is communication, communication, communication. You cannot over-communicate enough. With regards to management of the pandemic or disaster response, that's also the first chapter of disaster management is communication, communication, communication. So I think we did well enough with our just-in-time communication. As we look back, I think that would be an area where we could go back and construct platforms and devices and formats to further enhance our communication as this was unfolding. A lot of this was done by telephone, the game of telephone in air quotes, not the telephone itself, but person to person, with some degree of codification of, I'll say, directives by email and documentation. I think we could have done better with a formal codified method of numerical itemizing of our directives. Today, we will have EMS pause at the EMS bay, Directive 1. Directive 2 is today, Directive 1 is no longer the case. We will have the EMS doors locked. Very simple, but we didn't quite accomplish that, and so there's always people in the caboose of the communication train that get the message a little bit late or not at all, and so either they're offended or, more importantly, they aren't in compliance, so we break our process, which could, in this case, could actually be detrimental to health of other patients and providers. I think we're fortunate, by and large, we didn't have that, but I think we could formalize our communication strategy in the next pandemic response.
And what is an individual emergency physician? What were the largest challenges in the actual bedside care of these patients that you've learned about caring for the COVID patient, or if you had to do it again, you might go about it differently?
The biggest surprise or evolution, if you will, of COVID is that in our phase 3, where if phase 1 is vertical, phase 2 is mixed, phase 3 is horizontal. So in our mixed phase, as we started to learn more about how COVID progressed to this rapid deterioration of respiratory status and the significant progression of not just one organ failure, that is with pulmonary failure, but in our at-risk community, our frail patients, the rapid progression to multi-organ system failure. So recognizing that COVID-19 may present now with altered mental status. And of course, at any stage in what I'm making up as phase 1, 2, or 3, it could have done this, but what we're seeing is more and more of these patients that are diabetics, they're renal failure patients, and they may just present with altered mental status, but in fact, you find that they're hypothermic or hyperthermic, and then you find these diffuse bilateral opacities that are in fact COVID pneumonia, but they're not presenting as that. We saw more and more of that as the disease spread out into the frail community. So that's been the learning point. And I think what we now go by is we just have universal precautions for COVID. And I think that's best represented in a case that we had just last week. It was COVID-19 presenting as stab wound to the chest. And so
Oh my gosh.
Right? So this 30-something-year-old male suffered a stab wound to the chest, came in and kind of uncharacteristically needed to go from the emergency department after initial stabilization, resuscitation, to the operating room for this stab wound. Day 2 of his hospitalization, developed a postoperative fever, but was otherwise okay. Day 4, developed a infiltrative pattern that was more significant for not post-op stab wound injury, but in fact COVID. And then finally, day 6 post-op, we got the COVID-19 test results back positive for SARS-CoV-2. So that's where we're at. This is a universal disease now in this community, and we would certainly expect many large, dense communities to experience the same transition of COVID-19.
That's really an incredible point. That what I'm hearing you say is that the CDC table that you see about cough, fever, malaise, but as you're getting more experience with it and the disease is getting more settled in your community, you're seeing more of these atypical manifestations. So you're casting a much broader net, is what I'm hearing you say.
Exactly right.
That's really incredible. Now, on a personal level, obviously for our physicians and our nurses, this is, putting one potentially in harm's way. Have you modified your pre-shift or post-shift rituals on how you prepare for a shift, or what do you do after a shift for maybe your own protection and safety and that of your family?
Dr. Guy, I am not the best example of perfect, disease, communicable disease prevention. With that said, I am a big proponent of hand washing, so I've been relatively diligent around hand hygiene. I've advanced personally to the appropriate personal protective equipment. With that said, I'm a big cheerleader for nursing and the other providers to make sure that they are more stringent with the appropriate level of personal protective equipment and good methodology and discipline around donning and particularly doffing. So I wouldn't use myself as an example at performance, but as I said, I'm a big cheerleader and I have been, almost every shift I take out personal protective equipment, so I know that every one of our providers has extra material, extra equipment at their fingertips, and I'm certainly sharing that with nursing. So that's been my input on a personal level. I'm not so good at that.
Is there any question that I should have asked that you wish that I would have asked?
What is my conclusion as to the fortitude, commitment, and passion of our emergency department team here at Regional Medical Center? And I would tell you, I am pleasantly surprised. I was going to say shocked, but I'm actually not shocked. But my expectations have been exceeded from the standpoint of when this pandemic was coming our way. I had early wake-ups thinking, oh my gosh, some of our crew is going to, science will get the best of them. And even though I know that they want to provide patient care, with the high rate of provider illness that we've seen in China and in some of the European countries, rates of 20, 30% of caregivers becoming infected, I thought for sure we would have people not show up, or even worse, get sick and need to go out. But if I had any real wood around here, I would absolutely be knocking with my head. We have been blessed that we've had minimal number of illnesses, and we've had nobody not show up just because of fear factor. So that really tells you that this group at Regional Medical Center, which I knew, it takes a special person to get up every morning and come to the east side of San Jose if they're not from the community and jump into what is controlled chaos in our trauma center. But to do that with a pandemic at hand, I think they've really proven themselves.
Well, I think that's a perfect place to leave it. I mean, on such an incredible high note, and recognizing the professionalism and dedication of you and your staff. Thank you for that. We've been talking to Dr. Paul Silka, who is the Emergency Department Medical Director at Regional Medical Center in San Jose, California. Dr. Silka, thank you for taking the time. My name is Jeff Guy from HCA. Thank you.
Thanks, Dr. Guy.